Hi, welcome to the Mind Institute, and I'm going to be talking about targeted treatments in individuals with Fragile X syndrome and also talk about Fragile X associated disorders in this lecture. I want to start with showing you the Fragile X gene. You can see it right here. It has a CGG repetitive sequence at the front end of the gene. Everybody has this gene, and right in the front end near the promoter region, it has from 5 to 45 CGG repeats, which produces a normal level of messenger RNA and normal levels of the Fragile X protein. This protein is very important for brain development throughout life, not just in early childhood, but also in aging. Now, the pre-mutation represents the mutation seen in individuals who are carriers of Fragile X. They have between 55 to 200 CGG repeats. This produces actually excessive levels of messenger RNA from this FMR1 gene, and usually normal levels of protein, although at the upper end of the pre-mutation, the levels of protein can be slightly lower than normal. The pre-mutation is just the opposite of Fragile X syndrome. In Fragile X syndrome, the CGG repeat is greater than 200, but the gene methylates, and so the gene turns off, and there is little or no transcription in males, although in females the normal X is producing some message. This leads to a lack or a deficiency of the Fragile X protein, and that's what causes Fragile X syndrome. However, the excess messenger RNA can cause different types of pre-mutation disorders, including the Fragile X-associated primary ovarian insufficiency, also called FXS-POI, and this represents early ovarian failure or menopause before age 40. It can also cause a neurodegenerative disorder named the Fragile X-associated tremor ataxia syndrome, or FXS. It also is a very important cause of depression and or anxiety in pre-mutation carriers. And in some pre-mutation carriers, it can cause ADHD or hyperactivity, attentional problems, obsessive compulsive disorder, seizures in about 20%, and autism spectrum disorders in about 10%, particularly in young males with the pre-mutation. Now, the pre-mutation is much more common than Fragile X syndrome in the general population. In females, it ranges from 1 to 130 to 1 in 250 females, although in some parts of the world it's very close to 1 in 100, such as Israel or Colombia. And in males, it occurs in about 1 to 250 up to 810 in the general population. And the full mutation can occur in 1 in 3,600 to 1 in 5,000 in the general population. So the pre-mutation is much more common than Fragile X syndrome. Now, this just shows the level of messenger RNA here and the level of the Fragile X protein, or FMRP, here, and this is the CGG repeat number. So the gray zone is between 45 to 55 CGG repeats, and it's gray because we don't really know for sure what types of phenotypic involvement is associated with the gray zone. We see many patients with autism spectrum disorder or Parkinson's disease with the gray zone, but the research still has to be done to look carefully at gray zone involvement. The messenger RNA level is about twice normal in the gray zone. And then the pre-mutation here between 55 and 200 repeats is where we see individuals with FXS and FXS-POI. And then at over 200 repeats, the gene is methylated, and this will shut down messenger RNA production. But individuals who are partially unmethylated are still producing some levels of messenger RNA. And these are typically high-functioning males, or if they are mosaic with some cells with the pre-mutation and some cells with the full mutation, they will be producing some messenger RNA. Those with Fragile X syndrome have more than 200 repeats, although at the upper end in the premutation range, the level of protein may drop to about 40 or 50% of normal, and then they can have some features of Fragile X syndrome in this region. Now, FMRP is a very important protein. It has many functions. It is a controller protein. It controls the expression or the translation of many hundreds of other messages related to synaptic plasticity. It also transports messenger RNA to the synapse, particularly those messages whose proteins are very important for synaptic plasticity. So the absence of FMRP causes dysregulation of many pathways, including the mGluR5 pathway. Many other pathways are upregulated because the lack of suppression of translation is missing, so there's an increase in proteins throughout the brain, but particularly in the hippocampus. One of these proteins is matrix metalloproteinase 9, or MMP9, and we use a targeted treatment of minocycline to bring down the levels of MMP9. The use of mGluR5 antagonists are another targeted treatment, which we'll talk about in a moment. But there's also downregulation of the GABA pathways, or the inhibitory pathways. There's dysregulation of the dopamine pathways. There's enhanced amyloid precursor protein production. There's increased oxidative stress in neurons, and there's an enhanced release of neurotransmitters presynaptically. FMRP controls many important channels, such as the BK channel, other potassium channels, and the absence of FMRP, again, leads to dysregulation in these channels. Now, I want to point out that once you identify an individual with Fragile X syndrome, whether they have autism or mild intellectual disability, as we see here in these two kids, then you have a whole family to deal with. And this mother here has several premutation disorders, including FAXPOI, anxiety. She has a lot of neuropathy pain. She has muscle pain, which was eventually diagnosed as fibromyalgia, and she has autoimmune disease, including lupus. And we do see an association between autoimmune disease and the premutation in some females. Her mother here, or the grandmother of the children, has FAXTAS, and she also experienced FAXPOI, but her cognition is normal. And then her father here is much older. He has FAXTAS in addition to cognitive decline and dementia, but he has neuropathy and pain in the lower extremities also. Pain can be a very important symptom in those with neuropathy or FAXTAS or fibromyalgia, and many of these individuals have been put on opioids to control the pain, but we think that opioids could exacerbate neurological deterioration in premutation carriers. So this is an important problem. We also think that alcohol can progress FAXTAS and other substances of abuse. So this is part of the counseling to avoid these substances that could cause an increase in toxicity. Now, there's some areas in the world where Fragile X is very common. One of these areas is in Ricaurte, Colombia. This is near Cali, Colombia, right here. And this is a family where the mother has FAXTAS. She actually has 3 sons with Fragile X syndrome. Here are 2 of them. This is her daughter, who does not have the Fragile X mutation, so she inherited the normal X from her mother. But here's another daughter who has Down syndrome, but when we tested her, she also has Down syndrome and the Fragile X full mutation. So she has Fragile X syndrome and Down syndrome. She is severely hypotonic, very low verbal skills. She is in her late 30s, and she is already starting to have some cognitive decline. This is related to Down syndrome, but may be an additive effect from Fragile X syndrome. Now, here are 3 carrier women. These are daughters. This woman is the mother, is not the carrier, but their father is the carrier. And all daughters of carrier fathers have the pre-mutation themselves because they inherit the only mutated X, but it stays as a pre-mutation when it passes father to daughter. But all of these women are impaired. This one was selectively mute with some autistic features. Since childhood, these 2 have had cognitive decline and seizures, particularly after using phenobarb. So we think phenobarb could have added to their neurological problems, and that may be a medication to be avoided if you have the pre-mutations. So we're studying that at the moment. But in this area, in Colombia, the pre-mutation is quite common. About 1 in 50 to 1 in 100 women is a carrier, and a very high incidence of Fragile X syndrome. The clinical features of Fragile X can include a long face, slightly prominent ears. This boy has strabismus, or this eye turns in slightly, so he has a lazy eye. And in fact, when he was diagnosed with Fragile X, he already had developed amblyopia in this eye. So it's important for individuals with Fragile X syndrome to see the ophthalmologist. As you can see, his shirt is chewed, and excessive chewing is a feature of Fragile X syndrome. His fingers are hyperextensible, his thumbs are double jointed. Here we show testicular size in males. This is age here, and this is testicular size, and the top 3 lines are individuals with Fragile X syndrome. So their testicles are 2 to 3 times normal size. The bottom 3 lines are the general population, and this represents about 180 males with Fragile X syndrome. So the average size is about 45 to 50 ml in testicular volume, which is 2 to 3 times the normal size. So large testicles begin to occur in early puberty. They stabilize by mid-puberty and stay 2 to 3 times larger, sometimes even larger than that. And this is 70 to 75 ml in volume. So this is pretty large testicular size. Other features include hand flapping, poor eye contact, tactile defensiveness, unusual hand mannerisms, and perseverative speech. And these are all autistic features seen in Fragile X syndrome. About 60% of those with Fragile X syndrome can have autism or autism spectrum disorders by DSM-5. Each of these diamonds represent a separate patient with Fragile X syndrome, so you can tell that the autistic features are on a continuum here. And these are the repetitive and restricted behaviors that are seen throughout the range of autism or no autism, but the social and communicative disorders represent the core symptoms of autism in Fragile X syndrome. And again, this occurs in about 60% of those with Fragile X. Therefore, anyone diagnosed with autism or autism spectrum disorder needs to have a Fragile X DNA test, and that's very easy to order, and it is covered by insurance companies. So individuals with Fragile X can overreact to sensory stimuli. There's a lack of inhibition, that is, the GABA system doesn't work very well. So their habituation, and here we measure that as a sweat response, shown here, to repetitive stimuli, shown here. And these vertical lines could be auditory or visual or tactile stimuli. But normally there is a process of habituation, that is the sweat response, represented by the sympathetic system calms down with repetitive stimuli, but in Fragile X syndrome it actually activates because there's no GABA inhibition here, and that's why they can overreact to sensory stimuli and even have an aggressive or violent outburst, and that's quite a common problem in those with Fragile X syndrome. You can also have a point mutation. It's a rare cause of Fragile X syndrome, but a point mutation in the Fragile X mental retardation 1 gene or FMR1 gene can cause Fragile X syndrome, so you don't have to have a CGG repetitive sequence. This is a published case here, and this is one of the cases seen at the Mind Institute. This boy has 25 CGG repeats, but when whole exome sequencing was carried out, he was found to have a point mutation right here in the FMR1 gene, and that has led to his features of Fragile X syndrome. He's actually more severely involved than the usual case of Fragile X syndrome. He's 11, but he is nonverbal. He has severe ASD. He also has ADHD, very hyperactive, and he has seizures that are partial complex seizures that are very difficult to control even with 2 anticonvulsants. Most of the time, seizures, which occur in about 20% of individuals with Fragile X syndrome, are easy to control with anticonvulsants. Now, there is dramatic upregulation of proteins in the central nervous system without the suppressive effect of FMRP, and this just shows the suppression of this mGluR5 pathway. So when there's an absence of the Fragile X protein, as in Fragile X syndrome, there is upregulation of these proteins which internalize the AMPA receptor, and that leads to immature and weak synaptic connections, as you see here. And that's why it was thought that treating with an mGluR5 antagonist would cure this problem in immature synaptic connections and cure Fragile X syndrome. This just shows the upregulation of protein in the knockout mouse model of Fragile X syndrome in the hippocampus compared to the wild type here. So there's about 20% more protein in the hippocampus and throughout the brain in Fragile X syndrome. So the mGluR5 antagonists were tried first to cure Fragile X syndrome. Lovastatin is also a medication that downregulates this mGluR5 system through the MEK-ERK pathway. And we're recruiting now for a controlled trial of lovastatin combined with intensive parent-implemented language intervention in individuals with Fragile X syndrome between the ages of 10 to 17. So if you're interested in this trial, give me an email and I'll show you where to do that. I'm going to show you the results of some of these mGluR5 antagonists in a moment. Also Arbaclofen, which is a GABA B agonist. Also the results of our Minocycline study, which lowers MMP9. Allopregnanolone is a GABA A agonist that we are using now to treat FXS in an open label trial, and we have just finished a ganaxolone study and we're analyzing the data now about how this GABA A agonist is working in Fragile X syndrome. So this was the first mGluR5 antagonist that was tried in Fragile X syndrome, Phenibom. This is a Fragile X boy that carried out this trial, and we were very impressed in how well he did during this trial. So was his mother. He had improvements on an attentional task and also on pre-pulse inhibition studies. And so we thought that this medication would continue to be very helpful. However, Neuropharm, the company that made Phenibom, actually went bankrupt after a long-acting fluoxetine study did not show efficacy in individuals with autism spectrum disorders. So Phenibom is no longer available. There are other mGluR5 antagonists that have been tried. One is AFQ-056 made by Novartis. another mGlu5 antagonist made by Roche. But both of these studies did not show efficacy in adolescents and adults. And this paper was recently published in Science Translational Medicine. The Roche data has not yet been published, but it will come out soon. It is important to realize that many families thought these medications were helpful for their children, particularly in cognitive areas, but there were no cognitive outcome measures in the Novartis or the Roche study. There was a reading program that we wanted to look at, but that was canceled when the primary controlled trials showed a lack of efficacy. We hope to get funded for a neuronext study using this mGlu5 antagonist in children ages 3 to 6 with Fragile X syndrome in a multi-center trial. And we hope, if it's funded by NIH, to begin that at the end of the year, because there's some evidence that younger children will respond better to targeted treatments for Fragile X than adolescents or adults. I want to mention Arbaclofen, which is a GABA B agonist that works presynaptically here. It lowers the amount of glutamate that comes out of the synapse, which lowers the mGlu5 stimulation and therefore lowers protein production. And it is far more powerful than regular baclofen. It's a racemic form. And in the preliminary studies, the clinical global improvement scale showed that those with Fragile X and autism, Arbaclofen is in the light blue or turquoise here, showed efficacy, whereas those with social deficits also showed efficacy, but the overall group wasn't quite statistically significant. So phase 3 trials were carried out first in adults, as you see here above, and then in children. And the adults did not show a benefit, but in children there was a benefit, not in the primary outcome measure, which was the aberrant behavior scale social avoidance subtest, but it wasn't quite significant. But the irritability subtest was significantly improved on Arbaclofen, and the parent stress scale was significantly improved. However, Arbaclofen was not successful in a controlled trial in individuals with autism without Fragile X syndrome. So the company, Seaside Therapeutics, went bankrupt. Now Autism Speaks has Arbaclofen. I think they are going to carry out more studies in those with autism, but not in those with a Fragile X syndrome, which is too bad because I think it can be helpful for many families. I want to point out that Minocycline is an antibiotic used commonly to treat Rocky Mountain spotted fever, also for acne treatment in adolescents, but it lowers matrix metalloproteinase 9 levels, which are way too high in Fragile X. Lithium is also a targeted treatment, which lowers GSK3 beta, and in an open label, it was helpful for individuals with Fragile X syndrome, but it hasn't been studied yet in a controlled trial, although it's quite helpful in animal studies. Minocycline was extremely helpful in animal studies, and the human trials include a retrospective study, but also an open label study that showed efficacy. Minocycline was not helpful in an autism study with a small number of patients, but in Fragile X syndrome, it did show efficacy. I want to point out that sometimes it can cause darkening of the teeth or graying of the teeth, and occasionally it can cause darkening of the nails, the fingernails, or toenails, as you see here in this individual who has been on minocycline for a year. Minocycline not only lowers MMP9 levels, which strengthens synaptic connections, but it's also an anti-inflammatory medication, and there may be some inflammation in the brain in individuals with Fragile X syndrome. That's a new area of study. It's also an antioxidant, and we know there's oxidative stress in the neurons in Fragile X syndrome and also in premutation carriers. It's also anti-apoptotic, so it prevents neuronal cell death. But perhaps most importantly, minocycline can stall translation. Remember how I mentioned that FMRP inhibits translation? Well, minocycline actually stalls translation, so in a sense it may slow down the overproduction of more proteins in addition to MMP9, and we think this can be part of the reason why minocycline can be helpful in animal and human studies. We carried out a controlled trial of minocycline. It was a crossover trial, each arm lasting 3 months with a variety of outcome measures as seen here. And what we showed on the clinical global improvement scale is that there was a significant effect on the CGI-I, as you see here in blue, even though there was a placebo effect also. Again, this is in children, and so it's not unusual to find a placebo effect in this very important time of development. It's actually a developmental effect. But most importantly, on event-related potentials, we saw that the habituation deficit improved with minocycline, whereas it did not improve with placebo. Placebo is in green here, and minocycline is in red, and this is habituation to an auditory click paradigm. And it brought back normal inhibition here, in addition to impacting the amplitude of some of the event-related potentials. So we think that the ERP is maybe a good outcome measure for some treatment studies in Fragile X. We can see elevation of MMP9 levels here in Fragile X syndrome compared to controls. And in this study, a few patients had MMP9 levels done. So at baseline, it was too high. Then it came down with minocycline, and on the placebo, it bounced back up again. So some individuals have higher levels of MMP9 than others. And so you can see here how MMP9 levels may be a biomarker and could identify maybe those that would respond best to minocycline by having very high MMP9 levels. I want to talk here about sertraline. And sertraline is an SSRI, meaning a selective serotonin reuptake inhibitor. It blocks the reuptake of serotonin at the synapse. This is the synapse here, so it allows more serotonin to stay in the synapse. The serotonin system is very important for the brainstem area, but occurs throughout the brain. And in young children with autism, there is a low level of production of serotonin. As you can see here, the open circles are those with autism. The closed circles are normals. And in those under 5, the serotonin levels, particularly in the frontal region of the brain, seem to be low. There's also some metabolomics information, a study here done by Boccaccio, showing that in the lymphoblastoid cell lines in individuals with autism spectrum compared to those with other neurodevelopmental disorders and controls, that there are deficits in tryptophan metabolism up until serotonin, as I'll show you here. And there are low levels of gene expression in this tryptophan metabolism pathway. And here's tryptophan coming into the cell. It gets metabolized to serotonin here. And all of these enzymes that metabolize tryptophan are all downregulated in autism spectrum disorders, but not in other neurodevelopmental disorders. So this may be another reason why there's low production of serotonin in autism and in seemingly all forms of autism. So sertraline also stimulates neurogenesis in both animal models and in humans. It stimulates brain-derived neurotrophic factor, or BDNF. It has a calming effect on the anxiety that emerges in the second year of life in young children with Fragile X syndrome and in many children with autism spectrum disorders. And sertraline also seems to stimulate speech and improve language. This may be a secondary effect of less anxiety, but it can also stimulate dopamine in the striatum and the nucleus accumbens. So a subgroup of individuals with Fragile X treated with sertraline can have improvement in their attention and focus. This is a retrospective study we did looking at young children. Here's their ages down here. Either those treated with sertraline clinically or those who did not receive sertraline, and there's a difference in their language trajectory as measured by the Mullen expressive language subtest and also the Mullen receptive language subtest. So the trajectory is significantly different and improved when they're on sertraline. So this data actually led to a controlled trial of sertraline, very low dose, just 2.5 milligrams to 5 milligrams in young children with Fragile X ages 2 to 6. And this study lasted 6 months. And as you can see, half of the children were on placebo and half of the children were on sertraline. A couple of individuals in each category actually dropped out. But here is the CGI-I. The green is on sertraline, the purple is on placebo. Now in this age group there is a lot of normal development in language abilities. And so you see improvement in language abilities even on placebo. This was not significantly different, although there seems to be a subgroup that responds extremely well to low-dose sertraline. Not everybody responds. But on the Mullen scales of early learning, the overall cognitive T-score was significantly better in those treated with sertraline compared to placebo. So these are the months gained on sertraline minus the months gained on placebo, and it all goes in a positive direction. Also, visual reception and fine motor age equivalent scores were significantly improved on sertraline. So the overall cognitive T-score, visual, perceptual, and fine motor were improved. The receptive and expressive language score were a bit improved, but it wasn't significantly improved in this controlled trial. But it all went in the right direction. So in conclusion, this controlled trial of low-dose sertraline in young children with Fragile X syndrome showed that visual perception and fine motor subtests significantly improved along with the overall component T-score. And there was a subtest from the social participation subtest of a sensory measurement that was also improved. It was safe in this age group without an increase in adverse events compared to placebo. Even though our primary outcome measures, the CGI-I and the receptive and expressive language scores, were not statistically significantly improved, this preliminary study showed that there was some significant improvement, particularly in the visual perception and the fine motor subtests. And so the families wanted to continue on sertraline after the study was completed. Now we are carrying out a controlled trial in children with autism spectrum disorders with low-dose sertraline, just 2.5 to 5 milligrams, depending on their age. And if you are interested in having your child participate in this trial, you can email me at rjhagerman@ucdavis.edu, or our coordinator, Lindsay Derby. Her email is here, and we would love to have you participate in this study. This study requires that individuals need to be in a behavioral treatment program for autism. before entering this study, but we do think that low-dose sertraline can have a very positive additive effect to young children with autism spectrum disorders. So we would love to hear from you, and just give us an email if you're interested in participating in this trial. There's no cost, and in fact, we reimburse you for travel to participate in this study. We have completed a ganaxolone trial. We're analyzing the data now, so we're excited to see how a GABA A receptor helps behavioral features in Fragile X syndrome. We also know that yoga and mindfulness meditation can improve GABA inhibition. And here is a very high-functioning guy with Fragile X syndrome who does yoga on a daily basis, and he says that it really helps his behavior and clear thinking. We have carried out a study of the IGF-1 analog named trofinetide, made by Neuren, and this downregulates the ERK and AKT activation, which is upregulated in those with Fragile X syndrome, and it brings that down in the animal models, and the preliminary studies show some beneficial effects, particularly at the high dose. And so Neuren will carry out further studies of this, hopefully in younger ages, if the FDA approves this. So we're very excited about this IGF-1 analog in children with Fragile X. I also want to point out that vitamins and antioxidants can be important in individuals with Fragile X syndrome. This has been shown to be beneficial in brain neurochemistry, increasing BDNF levels in the knockout mouse, and so we recommend omega-3s along with vitamins and antioxidants in children and adults with Fragile X syndrome, and vitamin E and vitamin C, which has been helpful in animal studies, along with NAC, is now being studied in young children in Spain by Dr. Yolanda de Diego in Spain. We also want to point out that targeted treatments should also be carried out with educational programs, such as the intensive language intervention that we're using in our lovastatin study for those ages 10 through 17. So we would like to hear from you if you want to participate in that trial. These are some other devices that we have used. Dr. Hessel is carrying out a study looking at a digital device to improve attention and focus, and we've also done some reading studies with Headsprout in Fragile X, and that can be helpful too. I want to thank our collaborators, including the University of Southern California, who has collaborated with us on our allopregnanolone study and FAXTAS, which is looking positive. Also at the University of Colorado, Nicole Tartaglia, Maureen Leahy, Karen Riley, Jim Grigsby, and also at Rush University with Liz Berry-Kravitz, and La Trobe University in Melbourne, Australia, with Danuta Loesch and Paul Fisher, along with all of our collaborators at UC Davis, including my husband Paul Hagerman, and also Flora Tassoni, our molecular biologists. Thank you so much. And our clinical trials team and many of the other collaborators are shown here.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.